Okay, when we do cardiopulmonary stress testing, some of the indications that you want to terminate the test. Obviously, if your monitor's not working, you probably don't want to do the test. Just like any stress test, if you start seeing ST depression, T-way inversion, ectopy, an occasional PVC is not a big deal, but somebody who gets SVT, VTAC, increased frequency of multifocal PVCs, second or third degree heart blocks, exercise-induced left or right bundle branch block, progressive chest pain, sweat and pallor, if the blood pressure is getting greater than 250 or the diastolic pressure is getting less than 120. Failure for your systolic pressure to increase or drop with increased workloads. It means if your blood pressure doesn't increase as it should or suddenly drops by 10 millimeters of mercury when you increase workload, what's that tell you? That you lack pump function. You lack the ability to pump that out even at increased demands. If they're getting lightheaded, have mental confusion or a headache, cyanosis, nausea, vomiting, or muscle cramping. These are all reasons why you would want to stop the test. Indications for doing a test, the reason why I don't have a slide dedicated to that is because there is no real clear picture of why. A lot of times this test is done in research or in bigger institutions. Certainly if they have significant COPD, if they have a cardiac function abnormality, exercise, they're athletes. There's a lot of reasons you might do this, but there's no real clear-cut indications for doing this test. It is expensive, and not every institution can do that. In Kansas, I can only think of maybe, not counting the Kansas City area, I would say maybe 4 hospitals, larger hospitals in bigger cities, or certainly bigger cities that would do this test. So, not something you're going to see that often. That's why we don't dedicate a whole lot of time to it. Contraindications to doing these tests. These are relative. They're not all-inclusive. Recent MI and stable angina, second, third degree heart blocks. If you've got some ventricular or atrial abnormalities or that are rapid arrhythmias, if they can't do it, you would not want to do a treadmill on somebody who is a bilateral amputee of their legs. They're not going to be able to do it. Sometimes you're dealing with the elderly. They've got hip problems. In some cases, walking on a treadmill doesn't work, but riding on a bicycle does, etc. So you've got to look at those pictures. Severe aortic stenosis and CHF, uncontrolled hypertension. If you got some limiting neurological disorders that you don't have the muscle function that can work, dissecting aneurysms is not a good thing. Severe pulmonary hypertension, thrombophlebitis or intracardiac thrombus, recent systemic or pulmonary embolism, PE, you probably don't want to do this, acute pericarditis, a PO2 that's less than 40 on room air, or a CO2 that's greater than 70 on room air, or if they have their FEV1 on their spirometer that is 30% or less of predicted. These would be reasons that you probably would be thinking you might not want to do this. When we do exercise, we want to look at ventilation and we want to monitor certain things. We want to look at minute ventilation, tidal volume, respiratory rate, oxygen uptake, carbon dioxide production. Remember the respiratory exchange ratio, 0.8. It's the equivalent, ventilation is the equivalent to the oxygen part of it. If you recall that the respiratory quotient, we look at the relationship between oxygen consumption and carbon dioxide production. Alright, now this picture here you can see is pretty complex. It explains how we're able to look at what oxygen consumption is. And this is not a formula that you guys are going to have to sit there and calculate. So again, I'm not going to spend a lot of time here, but basically they look at the relationship minute ventilation, what your exhaled oxygen level is, your exhaled carbon dioxide level, and there's some calculations based on that you're able to determine, including your FiO2, you're able to determine what your actual oxygen uptake is in liters per minute or milliliters. And then basically there's a system where the patient's breathing continuously. We have O2 analyzers, we have CO2 analyzers, a computer, temperature, gas mixing chambers, and you breathe on this. What happens is you get hooked up, and you've got like a mouthpiece, or they've got like a headgear thing you can use. And every breath in and out throughout the exercise, every single breath is going into and out of the machine, and that's how they're able to determine what your oxygen uptake and carbon dioxide production is. We talk about respiratory exchange ratio, respiratory quotient. It's the ratio of CO2 to O2 at the mouth. At rest, it should be 0.8. What we're after when we exercise somebody is for them to reach what's called an anaerobic or ventilatory threshold. An anaerobic or ventilatory threshold is nothing more than a point where the muscles are producing more carbon dioxide than oxygen is being consumed. It's what we call hitting the wall. Bam, we hit the wall. We can't go any further. If we're not able to get the oxygen there to feed those muscles and those cells, but yet we're producing carbon dioxide, we can't get rid of it anymore, we're too tired, we hit a wall. And a lot of times after that, you'll find that's one of the reasons why your legs will ache and you'll get muscle cramps and all those things, is because your CO2 level is so high that it puts you in an acidotic state. Okay, so they look for, on this slide here, it shows you the relationship and the point where, and originally we had a linear curve between the carbon dioxide production to the oxygen uptake, and the point where you see that curve angling more upright and not quite so linear across is the point where you've reached your anaerobic threshold. The point where those two cross the center of that X would be considered that. And then the physicians use that to determine where should you have reached that point, because we're all going to reach that point if we exercise them. Even the most fit athlete will reach that point at some point in the exercise process as you're adding more and more work. When you reach that is the point that kind of guides us and says, okay, how far did we go? And based on that and some predictive values, determine whether or not you have an impairment in your respiratory system or your cardiac system. This here is just showing you another example of what I just said, a relationship of oxygen uptake to carbon dioxide production. Not anything I'd spend a lot of time on. And this last slide here again is a relationship between minute ventilation, which remember it represents oxygen uptake and carbon dioxide production. You start seeing, as you look across the graph at under the VO2 at about 3.0, you start seeing where there is more and more and more CO2 produced. You start getting a curve change. Now, this does not really show you anaerobic threshold as well as the last slide does. These are not slides, again, that I would spend a lot of time on. It's just something for you to be somewhat familiar that this is some of the stuff that they're actually able to measure doing at cardiopulmonary stress testing. So anyway, that pretty much concludes this. This is pretty short and brief. When we start talking about cardiopulmonary stress testing and metabolic studies and things like that, we're starting to get into some very advanced concepts of pulmonary diagnostics that are outside the scope of this course. You can actually take a metabolic cart that does this for cardiopulmonary stress testing and hook it up to a ventilator that a patient's on and measure oxygen uptake, carbon dioxide production, look at your metabolics of your body and determine whether or not, for example, you are feeding a ventilated patient adequately to ensure that you're not overfeeding them or you're not increasing their work of breathing because their CO2 is too high, etc. Not something that we typically do a lot. Again, first of all, you have to have an institution that would have one of these machines in the first place. And second of all, the few times that I have done it on a ventilator, it was for some research purposes. A dietitian that we worked with had gotten a grant, and we were making some protocols on what diet should be based on diseases and what put them on the ventilator. And part of that research study that she was doing also included needing the data from the metabolic study. So I'm sure in some places they're going to could tell you that they're going to use the cardiopulmonary stress testing in so many more areas than we'll do here. But again, it's kind of outside the scope of the average respiratory department or the average pulmonary function laboratory. So anyway, that pretty much concludes the last lecture of this course. I hope that you guys got something out of this and you provide me some really good feedback so I know what I can do to improve these audio lectures. Thank you very much.